Thank you. So with that, I'm going to introduce our panel. And so we have certainly Dr. Bettina Drake, who's joined us, Dr. Jacques Carter, who's also joined us. We have Dr. Waseem Hussain, and welcome, Dr. Hussain. It's good to have you with us today. And Dr. Hussain is with Luminis Health in Maryland. And again, you have the background information on all of our presenters. Dr. Leslie Deane. Dr. Deane is with Howard University, a urologist with Howard University, and Dr. Hussain is a primary care physician with Luminis. And we also have Dr. Garnick, and Dr. Marc Garnick is someone that I've known here in the Boston area for many years. He does an annual publication about prostate disease, and I know he's been very vocal on this whole issue of early detection screening. We also have Dr. Keith Crawford, who's joined us for this. So again, welcome. And now, Meredith, what I see in the middle of the screen is a PHEN ribbon. Does the audience see the panelist members?
Yes, they do, Tom.
They do. Okay. So great. So let's talk about this issue, which we know is one of the key issues as it relates to prostate cancer. And I would like to begin the discussion around just gaps that I see with primary care doctors, and ask the audience: do we have a reliable first line of defense for prostate cancer screening? And I'll ask that question, and I'll address it to the panel. So you please respond. Do we have a reliable first line of defense for prostate cancer?
No.
Okay. Dr. Carter, who is a primary care physician, said no. Dr. Garnick, what are your thoughts?
I have a great deal of thoughts on the wonderful presentations that were made.
Okay.
And a few practical issues. I speak to primary care audiences around the country about PSA-based screening. And this is one of the most complicated issues in medicine and cancer biology and cancer medicine that I think any either primary care physician or even oncologists face on a day-to-day basis. I think the task force has really been the most important and most widely used set of guidelines that primary care physicians use. I dare say that I'm very impressed by the the NCCN guidelines, which are far more detailed. But I must say, it's not really; those are rarely accessed by a primary care physician audience. They are very, very often used by medical oncologists and radiation oncologists for all of the nuances of various forms of cancer, not only prostate cancer, but I dare say it would be a rare primary care physician that actually, given the challenges that they face on a day-to-day basis, to go to multiple guideline recommendations, and they would end up using the CAT task force. I must say that I'm very discouraged by the fact that in 2018 was the last day that the task force provided guidelines. If you go to their website, which I essentially check almost on an every week or every week basis, their last set of information to the public was that they last met in December of 2023, which is now almost 2 years ago. If you take a look at the chronology of guidelines from the task force, they issued that guidelines in 2008, 2012, 2018. So it is exceptionally a long period of time. that the guidelines have not been reissued when there's a huge amount of information that could potentially provide a much more nuanced set of guidelines. Moreover, if you take a look at the research questions, of which there are 3 pages on the task force website, I imagine that the task force guidelines are going to be very, very nuanced. But the fact that Kennedy basically canceled the last meeting of the task force, to me, is a very ominous sign that we may not be seeing more new recommendations for quite some period of time. But that's a long-winded answer to say, I think primary care physicians do have guidelines. And I would say that the majority of primary care physicians in this country rely upon the United States Preventive Services Task Force guidelines.
Thank you. And I agree that the majority of them rely upon those guidelines. And again, that brings me. I still ask the question, Dr. Deane, what's your what are your thoughts? Do we have a first line of defense for prostate cancer?
Thanks, Tom, for the opportunity to be here. I think that it depends really on where you are in the country, which state you're in, which city you're in, and what the demographic of the population is that is being treated. And I think that first line of defense varies. Sometimes we see people coming in referred with very low PSAs who don't need a referral. And sometimes we see patients referred after deferment, and the PSA has been rising, and they get referred at a late stage. So I think it's highly variable. There are some primary care docs who are very astute with this and really understand the demographic of the population that they are caring for, and oftentimes they will screen and send patients in early. And then there are others who follow the guidelines pretty rigidly, and I think that's where omissions can be made. I think that's where some patients can suffer as a result. So I think it's highly variable.
Okay, thank you. Dr. Hussain.
In defense of primary care a little bit, I would say, yes, we are reliable, but I would also echo the points that Dr. Garnick and Dr. Deane made, that we're not a monolith. Training, what generation you are, all of those are critical factors. I think we have to think of the general concept of prostate cancer screening, early detection in the context of the basic fact that 100 million people in America do not even have a primary care doctor. There's a massive PCP shortage in America. So there's a third of the population that they use the emergency room as their primary care doctor. And then that is a recipe for disaster. So I would also kind of put that in there as well. Yes, we are very heavily reliant on the guidelines. The American Association of Family Physicians, the USPSTF guidelines, they are in relationship to some of the guidelines that Dr. Drake showed, much more conservative. And that's a problem, right? Like, I think we need to address that. So that's one issue that needs to be addressed. Those recommendations need to be updated. Dr. Crawford made a great point earlier on today that, we cannot, and this is true for, I think, much of cancer screening, much of public health screening, we can't fall into this easy habit of lumping everybody together, all the age groups together, all the ethnicities together. So much of good screening and doing the right things for patients are based on risk stratification. And when the narrative is just, hey, 55 and over, do a PSA till 69, like that is doing our country a disservice, and especially the patients who are hurt the most by this, which are Black men in particular. So I think there needs to be some reform on that level. I think the tech has to get better too. One of the hesitations primary care physicians have in doing the PSA test is the PSA test, frankly, has a very high false positive rate, and the very high false positive rate can be as high as 75%. And as human beings, as doctors, like, we do not want to scare patients with a test that's got a 75% false positive and say, hey, you may have prostate cancer. And then they go down the rigmarole of the workup, and then they suffer. And then they're like, doc, why did you make me go through that? So there's some hesitation there. So certainly the testing has to get better. I think things have really evolved in the last 5 to 10 years where unnecessary biopsies have really decreased in the context of the new biomarker technologies that are available and the new MRI of the prostate. And basically the more increased use of the MRI of the prostates when urologists see elevated PSAs. So I think, I feel like that still has not infiltrated the actual primary care community. There's still the 1990s, early 2000s thinking that this is a inaccurate test, and do we want to really create a lot of morbidity for false positive readings? So I think there's a lot to unwind here, a lot of Christmas lights to untangle before primary care can truly be that reliable agent at the cutting edge of prostate cancer screening.
Thank you. Thank you. Anybody else have a comment on that question?
Can I just add something to
yes.
So I think there's a huge educational gap. So for example, it's the common knowledge is that if a patient goes in, whether it be a Black or non-Black patient goes in and they talk about prostate health and they get a PSA, that patient most likely thinks that they're going to have a biopsy. And they've had friends that have had biopsies that have ended up in the hospital with a post-biopsy infection. And it's scary. I think one of the really important things for primary care physicians and for patients to realize is that if you do get a PSA test and it is quote unquote outside the normal values, you may not necessarily end up with a biopsy. More likely than not, you'll end up having an MRI. And in some places, if the MRI is absolutely negative and the PSA is between 4 and 10, for example, there's ample data to suggest that you can avoid a biopsy and you will decrease the likelihood of finding insignificant cancers and essentially remain equivalent with finding clinically significant cancers if the abnormal MRI is then targeted with a biopsy. Moreover, it's very important to know, for especially younger patients, that may prompt some genetic testing, which has implications for the patient's family. So it's not only the patient going in and understanding better that they may or may not need a biopsy if the PSA is elevated, but if there are certain circumstances, their being tested may actually have improvements for their family members.
Thank you.
Tom,
Thank you.
I think Marc makes a good point about the MRI. I think that in a lot of places, a lot of patients aren't offered the MRIs. I think that is, and I know for a long time we pushed, putting MRIs in the testing pool, if you will, for men who come in with high PSA levels. And I think it's very important to use that as a tool. So that biopsy you're not going to go in and get a biopsy just because your PSA is elevated. There are other things that may go on before you end up in a biopsy. That's a good point.
Yeah, Tom, I wanted to go back a little bit and wanted to go back to just some basics. It's not this static point of PSA testing. It's a point over time, multiple points over time. And that in itself could help guide clinicians and patients as it relates to what's the next steps. And then also, Dr. Hussain, I don't know if you want to comment on our pilot study that we did with you a couple of years ago. Was that helpful in at least identifying the patients and beginning them on this journey over the next couple of years?
Yeah, so we did a study in our system to just assess if there were ethnic disparities in our system, which is basically the suburbs of Washington, D.C. and Maryland. And our system's quite large, and there were clear disparities. And so we leveraged the power of the electronic medical record and Epic to really sort of shape physician behavior in terms of screening. So based out of the results of that study, like the things that came out of that were now current state in our primary care line, in what we call the storyboard section of Epic. Like there are prompts for every primary care physician every single time they open up a chart to say, consider a PSA in this patient, and then we also leverage the electronic medical record system to do a little bit of risk stratification. So if it's an African American male, if they seem to have risk factors, those signals will flare off to the primary care physician, even for African American patients as young as 40, all the way up to 75. So that was the impact of doing that study. It actually caused a change in the way that we screen patients in our primary care line using our.
And was that in the educational tools that we created, did that help the clinicians save time? Because it's about saving clinicians time. They can, if they're more efficient, they can better educate the patient. So was that the case? Did you find that with the PHEN tools that we created, was that more helpful?
So the two PHEN tools that we use even now in 2025, and we collaborated a couple of years ago, was, so we have lots of literature in the offices in every clinic. We have PHEN posters in the office that often patients will look at that, and that will initiate a discussion about prostate cancer screening. The PHEN website is a super convenient way to sort of have patients say, hey, consider going to this website to learn more about prostate cancer screening. And so, yes, it's been instrumental in helping raise awareness and increasing the level of screening that's being done.
The other thing that if I could just add one or two other things, it's the NCCN guidelines. I would take objection to one of them. If you've got a patient in their 40s and their PSA is 3 or 2.9, that is a definitely abnormal PSA for someone in their 40s, and that patient, in my opinion, needs to be much more fully evaluated. Likewise, patients on 5-alpha reductase inhibitors, and those are drugs such as Proscar or Avodart, finasteride or dutasteride. If that patient's been on those drugs for BPH or benign enlargement of the prostate gland, you've got to double their PSA. And moreover, if you're starting, for a primary care physician or if a patient is starting on one of those drugs for suspected BPH, that patient should know that they need to get a baseline PSA and have it rechecked in about 6 months. And if indeed that PSA is not down by 50%, that patient has a 3 times more likelihood of having prostate cancer and a 6-fold more likelihood of having advanced of a clinically significant prostate cancer. So those are some very important considerations that can get out to the public. That yes, if I'm a 45-year-old gentleman, my PSA comes back at 2.8, that's not a normal PSA in that population.
Thank you. Did you say, Dr. Garnick, at a PSA of 3 is at 40? I would certainly agree, and I think the NCCN guidelines would agree with you on that as well. I'm not looking at those right in front of me, but I think these are the conversations that we hope that primary care doctors will have. And the biggest issue that we see right now, and we see some great primary care doctors who will have that discussion, who will do early detection screening at 40 for high-risk men, but there's still, in my view, too many out there where we see men coming back saying that their doctors said they don't need to be screened until they're 55, and even with a high PSA. Recently had a man we supported, he was screened, had a PSA of 14. His doctor said that he didn't have no issues, and it didn't refer him to any other evaluation. I mean, that's just wrong. So those are the concerns that we have as we're on the front line of educating and supporting men. So thank you for that. I'm going to go even a step further. I'm not sure that we have a reliable first line of defense for prostate cancer screening. And I know Dr. Carter said no, we got some other inputs, but when we see the numbers say we do not. If we see it, more men being diagnosed with advanced disease, what that's telling us is that we're missing these men early on when their cancer is not advanced. So I'll ask another question. and that is, should the task force or the task force guidelines as written totally obsolete and outdated?
Yes.
Yes,
And should they be totally ignored?
absolutely.
Okay. All right. Now I saw another question was that does the insurers use the NCCN guidelines? That's a great question because the NCCN guidelines for treatment, insurers use the NCCN guidelines. I am not. I think I'm not sure that's the case for early detection screening. Dr. Drake, do you know the answer to that question?
No, I don't believe that they do. I believe insurers use the task force guidelines for screening. What's also, and I don't know if every medical school does this, but I know many medical students, especially even at my institution, are taught the U.S. Preventative Services Task Force grading system for not just for prostate, but for lots of conditions. And they know what each of the letters means, and then they kind of remember or are taught what to do based on those guidelines. So also thinking about how we're training the next generation of providers and what how they're going to treat those patients.
It's a great point. That is a great point. Dr. Carter, do you want to comment on that?
Well, I know that I'm in an academic institution, and I know that prostate cancer screening is not routinely done for high-risk men at many of the institutions around this town, because I think a lot of the doctors are still looking at the old guidelines, and they're stuck on the 2012 guidelines, not paying any attention to the 2018, which doesn't encourage screening anyway. I'm talking about the U.S. Preventative Services Task Force guidelines, and I think that that's where we have to sort of. I think this article in the New York Times and the Globe is going to do a whole lot to point up the fact that we should be screening high-risk men at a better rate than we are, and that the PSA blood test has a lot of benefits, even with all this negative pieces. And I think that that when they said don't screen in 2012, there was everything on television and all the news reports, and everybody knew about it. But nobody's talked about, men being diagnosed with advanced stages because we got rid of those old guidelines. And I think that the press is now playing a role in this. And I think it's important, and I think we need to sort of play this up and maybe try to get more articles in the popular press about the need to screen high-risk men and to have this risk-adjusted screening. We just got to do it. If we don't, we end up with these ugly numbers for years.
Absolutely. But I think the whole education that Dr. Drake brought up for primary care doctors, for medical students, if it's based upon these outdated task force guidelines, we're in trouble. Yeah. I mean, we know we're in trouble. Now we're getting further deeper in trouble. Yeah, and that's a scary situation. Yeah. That's the reason that we see they get the feedback, our patients getting the feedback that they're getting, because doctors are taught to adhere to those outdated guidelines.
Tom, I had a quick question from the standpoint of family practice. It's less about the medical students, but more about board certification. And if the board certification tests are based upon United States Preventive Services Task Force, that's the gatekeeper. Because for you to get certified and you begin to practice, you have to go through that. And if the board certification is based upon United States Preventive Services Task Force, then we're in trouble, because that has to be changed. That's that last point of contact. Medical student is gonna have is one thing, but the resident that's about to, a chief resident is like to finish their practice and get board certified, and every year clinicians go back to be certified, or every couple of years they go back to be certified. If we don't catch it at that educational point, then we're we're still going to still have a difficult problem here.
Yeah, we're faced with an issue now. That's one reason that we made this our first session at our 21st annual summit. We've been on this topic for many, many years, certainly since before 2012, and very much aggressively since then. But there's work to be done. In terms of, I would think that the insurers should consider the NCCN guidelines for early detection screenings the same way they do for treatment guidelines. I should let people know that I do serve on the NCCN early detection screening panel. I think I'm the only non-doctor on that panel as a patient advocate. And hopefully, I think I made a difference in them bifurcating their guidelines the way they have now. So we're going to continue to press on with trying to get these guidelines recognized as a standard. Now, I know that's a tough challenge, but if the article is saying that the task force is out of the game, someone has to take over.
Yep.
And so, yes, Dr. Deane?
I just wanted to say that I think as urologists, we need to change the narrative a bit, because for many years, like I think Dr. Crawford pointed out, this is not a one-time PSA value. It's about a trend. And I think that we have to change the narrative from what it was in the past, that one elevated PSA gets a biopsy for which there's only a 25% positive rate, rendering 75% of biopsies negative. And I think that has dissuaded a number of primary care doctors as well, in addition to the preventive task force recommendations. I think that we need to really set the expectation that the default position is going to be not to do a biopsy, but there are going to be interventions in the interim to establish what an individual patient's risk is, such that when we actually do a biopsy, the chances of finding something are much higher than that historical 25%. And like was mentioned before, that's going to include biomarker evaluations, a really robust assessment of risk, MRIs, and following the PSA to make sure that, okay, your gland is 80 grams, your PSA is 4.2, there are no lesions on MRI, your biomarker risk is low. Therefore, we probably don't need to do a biopsy because the chances of us finding cancer are low. And that mitigates a lot of the concerns in regards to moving to the next step.
Agreed.
Yeah, on that issue, Dr. Deane, do you think the biomarkers that we're using now, both for kind of halting overdiagnosis with the MRI, with PIRADS, and et cetera, and also for treatments with active surveillance, do you think that they are strong enough to prevent some of the issues that we saw many years ago with overdiagnosis and overtreatment?
Yeah, I think some of them are. The problem that we face in regards to the biomarkers are the data set that they're derived from, and their broad applicability across ethnicities. I think that those numbers may be different if you are looking at Black patients. For example, there's no way to robustly assess a biomarker that was evaluated in Scandinavian men in an African American population. I don't think that you can apply the same parameters. That has to be studied in Black patients specifically, and that leads us to another question and another avenue of investigation, which is the enrollment of African American patients and other ethnicities in clinical trials to generate this data, which then gives us a more a strength-based recommendation because we have an evaluation in the patient population that we are treating.
The other thing
Thank
that
you.
the other thing that I'd just like to mention is that just like a patient may think that an abnormal PSA will lead to a biopsy, even if a biopsy shows cancer, it's not necessary that the patient is going to require treatment. I mean, the use of genomic assessments of the biopsy specimen is extraordinarily helpful in doing and adding another piece of information to help the patient and the physician make a determination whether this patient is an appropriate candidate for active surveillance or intervention.
But aren't we needed to go back to basics? And that is that historically it's a history, family history, understanding the background of the patient is key. And if you come from a family that has 5 brothers and all brothers have prostate cancer, you're going to look at this patient much differently than someone who is classified as a low risk. And I agree about this whole issue of the biomarkers because the NCCN guidelines that's not the first line of approach, but we have that ability to look at the speed, the velocity of the PSA rising and look at PSA density. Nobody's talking about just the basic fundamentals on history and physical. And sometimes we fall away from the basics. And yes, you're extremely right about, I mean, one of the tests is Stockholm test. And I'm like, well, I'm not from, my relatives aren't from Stockholm. So from Europe, it's not likely that biomarker test is going to help my family and help me. But there's something to do to go back to just the basics of history and physical and understanding the patient. And then being able to monitor the patient and looking for changes in velocity and looking at density size as a basis, as a fundamental, and then moving on to an MRI. I recognize that a lot of people around the country won't have access to it, but at least let's begin that and start to collect our own real world data, real world evidence about screening. We can't wait for anybody to do it. We're going to have to start doing it ourselves.
Yeah, and okay. Somebody, was Dr. Garnick or somebody getting ready to make a point?
I think it's a really important point. In my own practice, if I see a patient, whether they're black or white, whose father had prostate cancer, whose brother had prostate cancer, whose uncle had prostate cancer, and and a strong family history, I will strongly recommend screening, but I'll also add that decision is based upon an emotional decision, because I really can't show that patient that any of these interventions is going to lead to an improvement in survival or a decrease in prostate cancer mortality. And if you so I would clearly screen that patient thinking that's the right thing to do. But if you come up with hard data to support that, it's very, very difficult. And in fact, during the public commentary period of the 2012 recommendation, the recommendation was made regardless of age, race, or family history. And the question came up during the public commentary period, how can you possibly make that determination that age, race, and family history should not influence your decision? And the answer was, we did not want to disproportionately, the answer from the task force was, we did not want to disproportionately disadvantage that population without data that the screening was actually leading to improvements in survival or cancer-specific survival.
But that's the fundamentals of medicine. So basically, you take the fundamentals of medicine away, then what are you supposed to do?
So you give your best, in the absence of data, okay, you give your best judgment for the patient, which you think is doing the right thing. And that's exactly what I do for someone with a strong family history of prostate cancer, that's even, outside the quote unquote guidelines in terms of what their age is.
Yeah, I think one of the big issues, especially I think with the task force and the way it does its evidence-based analysis, is relying upon trials that randomized controlled trials, and we know that there will not be another randomized controlled trial around prostate cancer screening. They couldn't make it happen with PILCO. You won't be able to make it happen, certainly not in this era. So it seems to me that you're going to have to rely upon more on real world evidence on those trials. And one of the things with the NCCN is we're talking about certain trials and real world evidence from those practitioners. So I think we had to go more with real world evidence than these randomized trials.
Does the
I'm
United
sorry,
States
what's
Preventive Service, does the United States Preventive Services Task Force, if they were still here or still functioning, do they use real world evidence?
well, I'm not sure. I'm not sure that they. I know they did not for 2012 or 2018. They used clinical trials, the PILCO trial for 2012. For 2018, they moved from a D to a C based upon the European trial. So it wasn't real world data here in the United States.
I think they went from a D to a C, mainly because between 2012 and 2018, there were many more men that were opting for active surveillance, thereby decreasing the harms of treatment, and the harm-benefit ratio had changed. It wasn't as though PSA-based screening from their analysis of the data led to improvement in either cancer-specific or overall survival, but the harm-benefit ratio had changed because fewer men were actually getting treatment with either radiation or surgery. That's my understanding of why it went from a D to a C.
Yeah, that's certainly one factor, but they pointed out in their findings that they certainly used, they cited the number for the European trials, one of the factors that they used for the 2018 change. So we still have a lot of work to do, but in the meantime, we look at these numbers where advanced disease is increasing, and that's because the cancer is not being caught at an early stage. So we have to act now while we're doing this work.
Tom, I think Dr. Hussain had a point. Or
Yes, Dr. Hussain, do you have something?
I think that's a good, I had a couple of just general thoughts that I was wondering if maybe Dr. Deane could chime in on. And Dr. Garnick had alluded to this. So this basic concept that, an age-adjusted, what is normal for a PSA, like the way we've been taught in primary care is 4 or higher is abnormal, 4 and lower is normal. And that's just not the case, right? So Dr. Garnick had cited the example of what if you have a 42-year-old and he's got a PSA of 2.8. So I think there's some education to be done there that it's a little bit of a sliding scale. Right? And by the same token, if somebody's 60 years old and they have a PSA of 5.5, like you're going to evaluate that situation differently than you would if the guy was younger. So I think that's something that that needs to be that information needs to be disseminated out there, really codified into the guidelines. The other thing that I think is very underrated, and this has been around for over 20 years, is just the role of dutasteride and finasteride in the prevention of lower grade and intermediate grade prostate cancers. There's men that I see every day, they're at high risk for prostate cancer. They're fine, their PSA is okay, they're getting screened, but these guys should be on dutasteride as a prophylactic agent. And it's not FDA approved, but there's plentiful evidence that has a really helpful effect on preventing cancer, especially in younger men. As they get older.
Can I ask you a question? Is that preventing cancer or just decreasing the PSA? So you don't go after the cancer.
It lowers the risk of cancer, but it also selects out some high risk cancers, I think, with use, which is why the medical oncologists have not recommended it.
So I don't know if Dr. Garnick
I was on the FDA advisory committee that looked at the use of dutasteride and finasteride as a chemopreventative. And that data basically showed that it did not get approved by the FDA. The data showed that you decrease the incidence of low-grade, incidentally found, non-clinically significant cancers with a definite but increased risk of high-grade cancers. And that's why it was not approved.
I'm sorry to interrupt. Could the panelists turn their volume up, please, for us?
Thank
Dr.
you.
But like that, what you just said, that was sort of the initial reason why I think a lot of primary care physicians were sort of like, well, I'm not going to use dutasteride for this then. I don't want to set my patients up for a high-grade prostate cancer. But
Yeah.
subsequent studies have sort of showed that that's a little bit of a statistical illusion. So what's happening with the dutasteride is it is decreasing not just low grade, but intermediate. And because it doesn't really have any effect on the high grade, so the high grade sort of gets sort of selected out and gives the
Yeah.
appearance that there's more high grade. So I just feel like that's a tool sitting in our toolbox right now today in 2025.
I would urge you to take a look at the prostate cancer prevention trial published in the New England Journal in 2002 and 2003, okay, as well as the subsequent discussions in the New England Journal relating to what was the effect of the increased incidence of high-grade cancer. At one point, we thought there was an increased death. Subsequent data has shown that there's not an increased death despite the increased incidence of high-grade disease. And it occurred both with the PCPT trial as well as the AVADOT, the reduced trial. So it's been a very, very controversial issue.
Yeah, you know, and the question in my mind, well, the question I have, well, who would make these recommendations? Would it be the primary care doctor? Because again, we're talking about recommendation prior to going to a urologist.
I think
so. If the primary care doctors are not engaged in this issue, then they certainly are not going to make that recommendation.
From my perspective, the important aspect about 5-alpha reductase inhibitors, finasteride or dutasteride, is that if a patient is going on it and a doctor is going to prescribe it, you should get a baseline PSA test. If that PSA does not go down by 50%, the likelihood of that patient harboring prostate cancer is extraordinarily high. And that's why I think BPH is so common, these drugs are so commonly used. That to me is a very, very important educational point.
All right. Well, I'm going to kind of move us on because we're getting into some details, and I'm not sure we have answers here today. So, does anyone have Jerry, Meredith? Do we have any questions, any relevant questions that we should present to our
I have them
from the audience? Yes,
I have
please.
them, Tom. So
Okay, thank you.
one of the questions, are insurers using the task force guidelines?
What was the question again?
Are insurers using the task force guidelines?
The insurers do use the task force guidelines, yes.
Okay. Are there other countries that have guidelines that are providing better mortality rates for prostate cancer?
Anybody want to address that question on the panel?
Well, I think it should be pointed out that the European randomized study for prostate cancer ended up doing a PSA test every 4 years. I mean, there were some studies, there were some centers in some countries in that study that did it every 2 years, but the European randomized study was basically every 4-year testing. Except for maybe Gutenberg and one of the other places.
I think the UK National Health Services are a little bit more aggressive as it relates to Afro-Caribbean screening or educating, because in their case, they're seeing numbers of 1 in 5 in the population. 1 in 5 Black or Afro-Caribbean men are coming down with prostate cancer. So they may be a little bit more aggressive than we are. And
okay.
Okay.
All right. Thank you. Any other questions?
It's also, I think it's also easier to get.
Hold on 1 second. Dr. Deane?
Yeah, I was saying, I think it's also easier to get an MRI as part of a screening program via the NHS in the UK than it probably is here. But it takes a discussion with the insurance company. And if a peer-to-peer is necessary, then what length is the urologist going to go to get that MRI approved for the patient? Some people go a really long way and have no denials. Others receive a denial and then say, your insurance doesn't approve it and there's nothing I can do about it. And I think that's a chasm in the whole spectrum of this disease.
I mean, we know the NCCN guidelines have made MRIs or parametric MRIs category 1 prior. So, but United States Preventive Service Task Force, I don't even know if they've commented on the use of.
No, it's not in their recommendation.
Okay.
Not at all.
It's in the research
Any other
program.
question?
Yep, just a couple more. Dr. Carter, going back to your presentation, can you summarize the recommended screening process for Black men, or Dr. Deane?
Well, I'm a proponent of the NCCN guidelines that we ought to be starting screening for Black men at age 40 with a baseline in the PSA. I think that we still don't have the data on the cut points. That is, when should that person, based on the result of that first test at age 40, when should that man have another one? We don't know that yet. And I think that that's some research that needs to be done. But we need to know at what level, based on age and the PSA level and the person's family history and genetics, when should the person get another one? But I think the NCCN guidelines are overall much better and more in line with what I believe as a primary care doctor than the task force recommendation.
Yeah, and they have, and what they have is PSAs with less than 1 should be repeated every 2 to 4 years. PSAs between 1 and 3 repeated every 1 to 2 years, and PSAs above 3 or suspicious DREs, they should follow more detailed evaluation and also possible biopsy. So they do stratify. The NCCN does a good job at stratifying even how often you should be getting your PSA test.
So I think it's also important to not use a blanket approach to this, because if you are starting off at 0.9 and you then repeat that in 2 to 4 years, it may have risen substantially in that period at the extremes. So I advocate for repeating it in a year and then maybe a year after that to establish stability and what the true baseline is, and then spreading it out sequentially thereafter.
Thank you. Any other questions?
Just the last question was about slides after, and yes, we will be providing copies of the slides today. And that's it.
And I want to remind the audience that this program will be rebroadcast at 6 p.m. So if you know of anyone that you think would benefit or like to join this program, they can do it with our recorded version at 6 p.m. So,
excuse me, Tom, there actually were a few more questions.
Are those relevant questions? I know I saw a few more questions, but some got into personal stories.
Okay. Yeah, there's 5 in the Q&A. I wasn't sure if you wanted to answer any of those. In the Q&A, look, you can take a look at those.
Take a look and see whether, in the meantime, what we would like to do while I'm doing that is to okay. Here's one. Let me put this out. To an untrained eye, the alarming data seems to speak loudly. Would an intelligent man include prostate examination, different from screening, in a regular annual physical beginning at 35? Anybody want to address that? I'll let the primary care doctors answer that question.
I think it all goes back to risk stratification. Like the answer is maybe, depending on risk. You have to really assess somebody's risk to truly answer that question properly. There are risk calculators. You can use those risk calculators. You can find them online. So if you want something really precise and objective to get a sense for somebody's risk and then make a decision about their PSA, I think that's one answer. To Dr. Deane's point, if somebody's at risk, even if they're very young, to just get a baseline so that a year or two later, you can sort of see where they're at there. You could make a case for that. But the guideline-based answer to your question is no. Not at all.
Is there, Tom, is there something about this, 10 years earlier than a family member that's developed?
But those are not in any guideline, Keith. I mean, yeah.
They're in colon cancer.
Colon cancer screening. Yeah.
Oh, are we
Okay.
gonna use colon cancer screening guidelines?
But the question was, would an intelligent man include prostate examination in the regular annual exam? I don't know which primary care doctor is going to give you a prostate examination at 35.
And I would
Okay.
also add that the likelihood of a physician being trained today being able to do a digital rectal examination is woefully low.
Yes, that's right. Absolutely.
He emphasized, I will see patients with prostate cancer in whom a digital examination has not yet been performed.
Yeah. Okay, so what we're going to do, I want to thank the panel for being with us today and giving some excellent insight on a very complicated question. And we really do appreciate your being with us. And I want to thank the audience who has remained steady for a while. I see some drop off now. I want to thank the audience for being with us for this program. Again, I want to remind you that it will be rebroadcast at 6 p.m. Eastern Time, and we invite you to come back again. And following that, this program will be on PHEN TV. So you will be able to, it will be available even as we go forward. I think we can still find our 2005 program online. So thank you again to our audience. Thank you for our panelists. And thank you again to our sponsors. Now,